When you're building in healthcare, you need to be able to empower how people work and how they heal seamlessly. Today, I'm able to interview the CEO of Texas Health Services Authority to explore how we can create systems that scale with human-centered workflow. We also discovered how Texas is able to use AI to prevent medical errors and rethink big data and interoperability. Plus, how we can earn trust across hospitals and homes. Now let's dive in. Welcome to Provider's Edge, the podcast that helps healthcare entrepreneurs and innovators break down barriers and control their business, life, and future with valuable action steps. With me, your host, Sabrina Runbeck, a recovered clinician and a business deal catalyst. Let's rewrite the rules and create a positive social impact while increasing your profitability. Hi, it's your host, Sabrina. We're at the Point Click Care Summit with Phil Beckett. He is from the Texas Health Services Authority and being in Houston, just like my hometown now. Well, I can say it's my hometown because I've been living there for almost 10 years.
Well, and I've been there maybe 30 years, but it's not where I was originally, right?
Yeah. And what brought us here is really the camaraderie of leveraging technology for interoperability. Tell us, what do you think is the reason why is it so difficult to share data, to have meaningful use of these data?
Well, Sabrina, again, thanks for having me. I'm excited to be here at this summit. Great people and networking. It's so powerful, and the opportunity to talk. That's a long question. Is why, and I ask myself, and I'd love to go back a little bit in my own history, but naively, and I believe I'm still naive, 30 years ago, as I moved into this career of interoperability, I thought this is easy. Retail solved it, energy solved it. They're competitive. They share data. I can use my ATM card anywhere in the world and get cash out of my own account. What's the problem? I just, take these lessons from these other industries and apply it to healthcare. Well, 30 years later, I now know that it's not easy like that. And there's so many reasons why it doesn't work. But probably, I think for me, the one piece that and we made a lot of advances, and we can talk through those, but I still think there's a lot of friction in that process. Healthcare data is messy, it's complex, there's a lot of it. Some people have, hundreds of pages of data. It's coded differently. So as a consumer of that data, say I'm a physician or a PA, and I don't have time to dig through all of that stuff. It's not easy, and if it's not in the workflow, if it's not automated, if it's not helping me, then I'm not going to use it. So I think I don't think this is ever a technical problem. We've got the technical tools to do this. It's a process problem. It's an incentive problem. Are we aligned financially to share data? It's a legal privacy problem. I think that's why I love this career, is because it's so complex and it involves all of these things, all of these layers, that it's not as simple as putting in a piece of technology to fix this. All you do, and I go back to kind of, the Henry Ford quote, if I asked the people what they wanted, they tell me a faster horse, and he came up with a car. And I think we need to think the same. If all we think about, we take healthcare today and we digitize those same things, we just make faster, bad processes. Not that all the processes are bad, but, I think we need all of us, young and old, and in our experiences coming together. And how do we truly transform the way we deliver healthcare? We got to think outside the box. We got great tools. Artificial intelligence, there's a lot of talk about that here. How does that play in there safely? But you can't just throw artificial intelligence at this and expect it to solve the problem. It's going to take us as humans to think through this and really think outside the box. How do we do that?
Right. It's about what we think the true problem is and what tools do we have to solve it. And if we don't, how do we create the tools to analyze that?
Now, AI is able to help us in a lot of ways, but it still need a human to design it, to ask the right question. And we use AI so much in different tools, in resourcing, in generating communication with patients, with Salesforce, and with marketing messages. But if you don't train AI the right way, you didn't give the right information, then it starts fabricating things, right? So hallucinating,
right.
exactly. So as we're sharing data, you also mentioned, which is the fear of what people are going to do when they see all the data. Our families and caregivers actually become super confused, that they feel like, oh, what are all these lab results? What are these red things? Are they truly out of bound, right? Because the lab usually they flash red for a little bit of elevated or too low. So is that clinically critical? They wouldn't know that unless we have a proper way to educate them on. And at the same time, if we're hiding those information, quote unquote hiding, but it's that we're not sure if patients should see all those, but then they feel like something is being hidden from them. And then all they're asking is this high level, are my dad and mom okay when they're in a hospital or in a long-term facility, because they don't have the insight, or the other insight is they start Googling everything, right?
Which is, and then you find out you're going to die tomorrow. Right. It's like it goes to them.
Right. So that's the multiple different layer of challenges. What do we use the data for? Who's getting it? And I also have seen friends who are heavy on the patient advocacy side to say, we are the patient, we should own the data, and then my data can be shared and sold to other people that do clinical trials if I so choose to. We should have the power. But then the question also brings that sharing of data, where do you store to be HIPAA compliant? And is that truly blockchain or something else that Web 3.0, whoever knows what that could possibly be,
right,
to help all of us to solve these questions. Right. So now you've been in the fields for decades after decades. What brought you to the Texas space to really help the health services in Texas?
Well, so going back, and you bring up great points, and I totally agree with you in this sort of education gap between physicians who've spent years at medical school understanding medicine, and you've got patients who understand nothing about that, and you share data between the two. That doesn't really work. And there's so many. Yeah, it's another of a really important barrier. But yeah, for me, if I can go back right to the beginning of my story, I was born in northern England on a dairy farm, and I was, as I looked at this industry that I was in as a kid, I watched these cows and a lot of grass going in the front and a lot of poop coming out of the back and not much milk. And I'm like, why are they so inefficient? What's going on here? So I went to college to study protein metabolism. That's the most expensive part of the diet. And it's also, anyway, I'm like, why are these creatures, why don't they convert all the protein they eat into milk or meat? Most of it comes out, and so I studied that for a long time, and then forward to the early 90s, and I came to Houston as a postdoc to the Children's Nutrition Research Center, and I was studying animal models first in protein metabolism, but then I moved to humans and to premature infants. And so in normal birth, when the fetus reaches term, it experiences stress of being squeezed in the uterus.
Yeah.
And that triggers cortisol, which triggers lung surfactants, so the infant can breathe the room air. So preemies never experience this. So they're born without lung surfactants. You put them on oxygen, which causes a lot of damage to the lungs. So you give them steroids to trigger lung surfactant, but that makes some protein breakdown, which is not good for these little guys. So I'm studying, can you have the beneficial effects on lungs without the negative effects on protein? So, but that was really transitional for me in like all these data silos, and even in the NICU, in the hospital, within the system. Remember, this is the early 90s. I'm doing this in the 90s. And there was, and there's paper charts everywhere, but not everybody had access to the data to make the decisions that they needed to make. So I really transitioned my career then to, I can have much more impact on people's lives through getting data to the people who can make decisions with it and use it, whether that's patients, physicians, nurses, community health workers, whoever it is, but appropriate sharing of data can really drive change in healthcare. So that's where I've spent the bulk of my career, but the bulk of that career has been learning why this is difficult. But I'm super passionate about that. I want to see change. I want Texas, but you see, we have the tools. We can manage chronic diseases. We have the medicine for that. We have the digital tools to coordinate care. It's not all tied together, and so people fall off the wagon, and it costs way more. Then you go to the emergency department with end-stage kidney disease, you're starting to cost a lot of money, and it's no fun for the patient. We've got the tools to either prevent or really slow that progression, but it takes communication and coordination of the patient, the family, or the clinical resources, community resources, and we have to think in models that way rather than the more transactional way that we think of in healthcare. Patient comes in with, problem, I patch it up, send them out again, end of story. That's kind of the way it is.
Yeah, it's that difficulty of sorting all those complexity through. Is what does that mean for us to have the power of data and not rely on this traditional way of seeing medicine as a reactive mode of this is what happened, we have symptoms, then it got diagnosed, and most of these acute care problems, people have no idea they have these diseases until it's diagnosed. Then they realize some of them are very late stage, and they now need surgery. They now cancer patient need a chemo, and not just early stage detection. And we can do something, then they can just go into remission, right?
Right.
So there's a lot of difficulty into the conversation. Now, what are you guys doing in Texas? What are some of the initiatives that you're doing right now? And also, what are some of the initiatives that you're hoping to do in the future?
Yeah, so I would say what we do now is super just foundational. It's basic stuff like patient matching. How do you know there's only one Phil Beckett? He's been to multiple places. Somewhere he's Phil Beckett, some places Philip, so he's got a dress type. They don't match up. So you've got basic things like that. We recently, there's a law change in Texas that hospitals can swipe driver's license to capture the demographics, standardize off the driver's license, and use that in their master patient index. So that distribute. We've also been working, again, this group working on baby naming conventions. When you have a baby, they name you baby boy, Beckett, or baby girl Sabrina, and or baby number 2. It all gets, and then when the baby gets a real name, those two records don't match up. So you've kind of got this, neonatal record with your baby boy, whatever, baby girl name, and then you've got your, next record. So stuff like that. We're also just working with our whole state and we've got multiple regional health information exchanges around Texas. Just how do we all work together to share data, and what are the financial models in that? In Texas, we don't get state funding to do these things. It's a model where we have to deliver value. So again, in the healthcare system, who gains benefit from data sharing? Hopefully the patient does. You're not asking them to pay. Health plans do. So working with them, they're a key part of this. Others, especially in the fee-for-service world, not so much, value-based care is a real driver for that. So value-based care is a key component of driving those. But again, I think you have to be careful with value-based care. And I see this, you're aware of this stuff. Somebody comes up with, hey, this is a quality measure that we should measure. But the physician on the other end is like, that's not really helping me with quality of care, so trying to get alignment with the whole community around that. But so I think we're still at that stage in Texas. We've done a lot. We've got a lot of interoperability going on. I think the next purge is making sure that people use that data, that it's usability. So focusing a lot more, not on the mechanics so much of data exchange, but on data usability and how is it in my workflow so that I know this patient, as I order a CT scan, I know they had one a week ago, and I can pull that up. So that's automated, it's driven, it makes sense to a clinician, the way that this works. So we're sort of in that stage. I think for me, and this is Phil Beckett talking, where I would like to see this go. One, I'm a big patient access to the records advocate too. I want that. But again, it has to be in a way that the patient can understand. And I also spend a lot of time thinking, don't have the answers, but how do you move things upstream so we're not being preachy to patients, to all of us, but helping us manage and coordinate our own care and think about long-term impacts of what I do around not just the clinical part of medicine, but all of those other things, of environment and of exercise and eating. And of course, we're all free to make our own decisions, but they should be data-driven decisions, I think, and so you're clear about what the potential impacts of this are. And I think another model that I'm trying to build, and just in my head at the moment, but is more that economic model. If you're the healthcare industry, you kind of rely on people needing stuff done to drive your business model. If we drive the population to be healthier and healthier, then there's losers in the healthcare sphere financially. So I want to build economic models for communities, again, maybe using AI and how you drive that. But remember SimCity, that game where you can kind of build a city. But imagine, you put in your own demographics for your community, whether that's a county, a city, a state, whatever, and then you can play it forward. Hey, I build more hospital beds, or I put in more community health workers. I vaccinate or don't vaccinate. You can play with these models and play it forward. And what does the economy, what does the health of my community look like in the future? And that work with city planning or community planning. Do I need more grocery stores here? Do I need more parks? Do I need more, orthopedic surgeons? What are the right answers? And how do I plan that based on data, historic data going forward? And how do we have healthcare that it's more around elective stuff? I do more facelifts and I do more, this stuff that yet our population we're treating less, chronic disease in the emergency department, that behavioral health is not taboo, or, that it's accepted. It's part of medicine. We invest in that and really help people, all of us. I include myself in that, I'm a patient plenty, and paint a picture of a future that focuses on wellness and health and less on disease.
Yeah, that's the big movement nowadays, is the longevity talk of food as medicine. What do we need to consume, supplement, or simply practice from what we call a 5-dimensional integration of the physical body, the labs, the disease state, but also movement, right? How people hire these high-end physical trainers to get your body stronger as you age, get your bone density. It's not just, I barely walk, I barely see the sun. And it's not just taking a bunch of supplement, but it's a customized way, right? There's a company that come out with either DNA testing to create what you process, where you're lacking, and as well as a very high-end nutritional plan based on what can you eat, and nutritionists in your pocket type of thing. Food as medicine is a new driver in a lot of topics.
Totally.
And seeing as a whole picture also from a spiritual side of who are we as a being, why are we doing things, whether we in medicine because that has been a childhood dream where we've seen people who has been such a detriment, and then we play into the role we wanted to be here. And just like your personal story, you gone through the pediatric side, research side, and you start seeing the gaps of I can't even do anything because of paper chart. How do we upgrade that using technology to help me find the better solution, and moving into the reactive to responsive, right, preventative medicine. And that spiritual side, I think, also help with the psychological side of what we see, especially from patient perspective. I'm healthy. I don't need to do anything. Why should I monitor my vitals? I know what to eat. To we should be able to, based on who you are, your comorbidity and lack there are, your family disease or lack there are, to create a customized package for you that's most helpful for you. Even down to even Ayurvedic medicine uses blood type, right? You process food differently even through your blood type and the shape of your body. And then you can, when you're thinking about gaining weight or losing weight, there's a different plan for that. It's not all size fits all. So as we start looking into those personalized medicine, putting the people in the center, we do have to think medicine as away from just this disease-driven physical type of solution, and adding the layer of mental health, the psychological behavior, and adding a layer of spiritual, not necessarily religion, but who are we as beings? What do we believe in? And that does affect, like Jehovah's Witness. When we do heart surgery, some people would take cell saver, means the blood that they lost, we can spin it and put it back to them. And some people are not even willing to do that, right? So we have to be okay with what they belief system and who they are as a being, adding to these physical, emotional, psychological layer to create that multidimensional of a person. And ultimately, my biggest drive in any of my work is also about resilience. How can we create sustainability that is selfishly actually feel good, life, fun, instead of, we have to make sure we motivate others to do the work. Instead of, we have to hire and we have to be that way already ourselves. Then we can add health to ourselves, to the organization, and the space of not burning out is continue to have space to innovate. Right? And that's the complexity of what we play in. And so for Texas, is we're already doing these things and we start looking into the community side. And for solution out there that wanted to really support the Texas medical community, patient community, I think he listened to what Phil mentioned earlier, right? How do we, number one initiative is bring in different profile and sync them. One solution you guys are using is swiping the driver's license.
Yeah, that's just with basic matching of all my stuff from different places. And there's more, and that's one. There's plenty other digital ways to do that as well.
Correct. So what other ways that you guys have shown, and that could be a great way to present. And then also from definitely from pediatric standpoint, some people use their legal name, some don't, and some abbreviate. So that can create a lot of identity confusion when it comes to your medical decision making and where your record is stored. I even have one of my colleagues that his social his social security number and his name was not exactly matching. Somehow it got duplicated, and then the system thought he has deceased, and instead of he was in the VA working as a provider, and so you can see it's multi-level of confusion.
It is. It happens plenty, I mean, there's good systems there, but it's not foolproof, and and we need to, and we have the tools. We can do better on that.
Yeah. So as people start bringing into solution, I think there's a thought process to say, what do we care about right now? Let's go from there. If you have a solution that can solve this, great. Pitch it, propose it, give us a clear plan what that looks like. And then also understand we know there's always a budget to things. If we're going to run a pilot with any community health center, then we need to make sure that those patients are ideal. They have the staff to do it. And then the city actually have a budget to wanting to do that. And so what is these solutions are able to actually get the return in delivering what you promise in a very clear thought process way for the rest of us who believe in this as a change can become the champion.
And I think, Sabrina, you bring up a great point there, is that money, it needs seed money to make this thing. But you said this before, sustainability is so key, or the resilience part of this. And it can't be a grant-funded part, okay, we do it during the grant, but then then once that goes away, everybody goes back to the old ways. I mean, it seems cliched, but I go back to the Uber, Lyft model, and it was really disruptive to the way we use transport, and it was sustainable. We still do it. It really changed the way things happen in a kind of permanent, in a quasi-permanent way, in a resilient way. And I think, we also need to think about that. As you think about community, which I go back to my, SimCity model that I got in my head here, is eventually, if you're going to involve the community and you're going to have community health workers doing some of this work, you got to pay them and you got to invest in that. And the money needs to trickle that way. And even more so, I'll joke. I know this doesn't make any sense, but I say, you should pay the community health worker as much as you pay the cardiologist, because the community health worker can potentially, by working together with people, reduce the need for the expensive stuff at the end of the day.
Right.
And I know that's a little far-fetched example, but I think it illustrates the point here is we need to think about our investments on the front end. And of course, we all need our own choices and freedom, and I totally agree with that. I'm from Texas, so individuality is what we need, but we should have the options if we want to be able to have this more holistic care that you're talking about. And I also think for business, if I'm speaking from a business, not from our own thing here, but just as a community businesses, if you've got employees who are healthy and happy and engaged, then they're spending 100% of their time thinking about the work, and they're more productive, they're more creative, they're at the top of their game. If they're worried about their, what's going on in their bodies, and it goes for all of us, it's natural, You're off your A game, you're on your B game or C game. That's not good for business. So as business leaders, as legislators, as community leaders, we should be thinking health and wellness and investing there and sustainable models there. And, anyway, I just think that's the way to...
Yeah, it's like, right, the integration of things, right?
Mm-hmm.
And then at the end of the day, interoperability is about integration.
And it's a tiny piece of it. It needs all of us. There's so many cool things here and people with technologies and all these, and we just need to all sit down together, and have that model, but that's sustainable, resilient model that we're moving forward together.
Yes. As we wrap up, I know something that I recently saw a post is that the government has been cutting significant funding into grants and NIH researches. Have we seen that a lot in Texas, and how do you think it's going to impact us?
Yeah, I mean, there is some. You're right. I see, and surely it is. And cuts in CMS as well are being talked about, and potentially in Medicaid. I think, and I've been talking about Medicaid spend as a unifying message. And in Texas, it's about a third of the state budget is on Medicaid, and I think everybody wants to reduce that. There's not disagreement there. How you reduce it, there's different questions on there, and I think you have to be careful. If you just take people off of Medicaid, they still get sick. They go to the ER, and it falls on the local taxpayer. So it really just shifts the budget. It doesn't matter. So I think, how do you make recipients of Medicaid cost less? And so that we're prepared for cuts in spending on Medicaid by really focusing on how do we spend as little as possible to keep that population as healthy as possible. I think one of the interesting numbers, when I look at the numbers in Texas, though, the Medicaid per capita spends about $6,500, I think, per year. The spend for the rest of us, or for all of us, is about $14,000. The per capita spend. So now these are mostly kids in Texas, so they're they don't have that, but the spend is less. So I wonder, hey, maybe there's lessons we could learn from Medicaid that goes the other way. But if you look at there's still 6,000. I think we could reduce that to 3,000 per and get the same health outcomes if we're strategic and think about that, and help the Doge, help bring down those CMS costs through better management. The biggest way, is administrative costs, pre-auth, all this paperwork that gets shoveled around, and chronic disease management. And, you take those two and really focus on what are the root causes of the problems in them, and how do we fix them? How do we, is that prenatal care? Where are those, where are the opportunities in cost without losing quality? And really drive those and work together as communities, drive down that cost. And I think we could really reduce the per capita spend.
Yes, unit economics, no matter what industry, is important. Is that, did you spend more money and get the same result? Or did you have a lot of waste in those money that we can really help to reshape, shift it? It's not to say those funding is going to go away. It's more like, let's use it in a better way that we can even support more of the communities and more people in need, and then getting better result overall. And as we wrap up, I always love to ask this question, a more of a fun question. If we give you a magic wand and you can use for anything within the healthcare of whether it's a Texas-based or your personal interest, to grant you 3 wishes, what would you use it for?
Well, and maybe so. I've talked about these a little bit already, I've given away. But if I'm going to be selfish, first, I think the Health Information Exchange infrastructure in Texas, because it is woefully underfunded. I would love to put more money in that so that they can help get over this hump. Get everybody connected, sharing data, and that be a sustainable, resilient model there. So that would be one. I think, the second would be, I really am, with all the barriers in place, but the patients have access to their own records. They are part of the solution here to sharing their records with providers, that they've got access to their own records in a secure place, and have the ability. And again, we've got the tools to do that today, but that was available to patients, for free. So I would love to fund that. And then the other is third, the one that I mentioned, is try to build an AI predictive model of healthcare economics, community economics, so that any, city planner or commissioner or legislator can go in there and mess with, or a data, a demographer can go in there and mess with the numbers and look in the crystal ball and say, this is what Texas looks like in 2035 if we go down this path, fork in the road versus this one. Otherwise, you're making decisions based on kind of guesswork or history. And we've got the tools, we've got the data, historic data, we've got amazing technology that can help us run out those models. So I would, love my magic $1 to build something like that empower communities to make their own decisions about where they want to go.
Yeah, that would be awesome. So for everybody who's listening, if you have ability to help Texas to increase interoperability, have ability to build that economic AI prediction model. And then the second one you mentioned was
patient access.
Patient access, right. Especially we know like Epic have a patient portal,
right.
But there's a lot of other platforms that don't have that option.
Right.
And then there are start popping out these patient portals from a long-term care standpoint. So how can we get in touch with these patient portals and things to get to the hands of the caregivers? And I start seeing those solutions as well, is that caregivers start saying, I don't really know what happened to my moms, whether they are in a hospital, in a nursing facility, in long-term, short-term care, and they're just simply worried and they don't have all the medical knowledge to ask the right question.
Right.
And to give them that reassurance and not be so fearful about sharing data, be transparent in that, and give people the power of the data and the resources, of course, done in the HIPAA compliant way.
Totally. Right.
And that actually helped to cut down a lot of human capital resources of calling back and forth. So leaving messages that you never know if they would actually call you back, right? So there's a lot of ways that we can really empower both the patients, providers, caregivers, as well as the policymaker, the payers, the insurers, and then the innovation family. So we can really connect all the dots. And that's definitely something that we already started doing. And I think we can do more and more intentionality behind it to truly push things forward. So how can people find you to have deeper conversation if they have one of those solutions?
Sure. No, that we're at thsa.org is our website. The info at thsa.org is the best way to reach us, and would love to talk and just share. Again, we're really a convener of communities. We have this interoperability collaborative run by Catherine Lusk. She brings together hundreds of people from around the state to say, what is it we need? And then go together in unison and say, this is what we need, electronic health record vendor. This is what we need, policymaker, to help us, so we got all these kind of advocacy, brain trust groups working together, not on, point solutions, but on a unified solution for the state. So it's a really powerful group. So I really see us as Texas Health Services Authority as a convener and facilitator of that kind of work, and get that from the crowd. Hey, what is it you really need?
Yes, amazing. So make sure when you have the idea, send it over. The more that you can help the community as a whole, the better it is. We just have to do it all together. And for anybody who are watching this, whether you're listening, watching on YouTube podcast or live streaming, we would love for you to connect with us, subscribe to the channel, and comment below. Really share with us what is something that you see interoperability can really do for your community, or you're already doing that as a company point solution to the community you're sharing. And then you can propose your idea to the Texas Health Services organization, where we can adapt your suggestions and see what we can do together.
Thank you so much, Sabrina. I really enjoyed it. I think it's great talking together. Thank you.
Thank you.
Thanks so much. Yeah.
Thank you for tuning in to Provider's Edge podcast. We hope you enjoy our latest episode and found the insights and tips helpful. We'd love to hear your feedback on the show and learn what topics you'd like us to cover in the future. So please take a moment to leave us a review on your favorite podcast platform and let us know what you think. Your feedback is essential to help us improve the show and provide you with the content you need to take your healthcare business to the next level. Thank you for your support, and we look forward to hearing from you soon.